Welcome and good afternoon, everyone. My name is Caleb Lavelle, and I'm the Director for the National Colorectal Cancer Roundtable, overseeing programs and partnerships. I'm so glad and pleased to be able to introduce the new 80% in Every Community Messaging Guidebook to you all and to help moderate today's session. So thank you all for joining. We have had a lot of interest in this topic, and we greatly appreciate your time, and we truly hope you will find this information as valuable as we do. So, during 80% by 2018, far and away our most popular and in-demand resource was the 80% by 2018 Communications Guidebook. In launching 80% in Every Community, we knew we would be well guided by refreshing this market research and the guidebook. We have found our efforts to be most successful when we ground them in up-to-date understanding of the unscreened. That means to take the time to understand their perceptions about colorectal cancer, their knowledge on recommended screening tests, their most pertinent barriers to screening, as well as the messages that are most likely to move them to action. The purpose of today's webinar is to orient colleagues and partners around the country to what to expect with the new guide and describe how we'll be able to use it in supporting 80% in Every Community efforts. We will also be providing an overview of the recent market research findings on the behaviors and barriers of the unscreened and introduce some of the new messaging for use in reaching those unscreened audiences. Finally, we'll be inviting you all to help us champion and disseminate our new guidebook, which we'll be launching next week. So to help me in completing these objectives, I'm joined by Michelle Albertine and Bill Willard. Michelle and Bill have been pivotal to helping us create this resource. Michelle, who works with KSNR, has served as the lead project consultant in conducting our market research, and Bill, who serves as Director of Market Research for Brand at the American Cancer Society, has helped to guide our team along throughout the process. They both are passionate about this work and have done a tremendous job in supporting these efforts. I'd like to share just a few housekeeping items before we get started. We are recording today's webinar. The replay and speaker slides will be shared with you all within a few days. Please feel free to share with your colleagues that weren't able to join us today. Also, because of the large number of participants, all participants are muted on today's call. We encourage you to ask questions by submitting them through the webinar Q&A function. We'll have time for questions after the presentations, and we'll answer as many as we can. We'll also be emailing around responses to any questions that we don't have time to get to. You can also email us specific questions afterward. And finally, we are always trying to improve our webinars. So we are asking for your help in evaluating the webinar. You will be receiving an email with a survey link. Please help us out with this by taking a few minutes to provide feedback. We take the advice very seriously, and we are always trying to improve. So before diving too far in, I want to just quickly level set on a few items before sharing our new market research findings, including discussing the 80% Every Community campaign, some high-level national screening data, and a quick summary of the messaging guidebook. 80% in Every Community is the NCCRT initiative which aims to substantially reduce colorectal cancer as a major public health problem. More than 1,700 organizations have committed to working toward the shared goal of 80% of adults aged 50 and older being regularly screened for colorectal cancer. And we know our shared efforts are working. Community health clinics, health plans, employers, counties, and others are seeing 80% screening rates and higher. But not everyone is benefiting equally. There are still too many communities with lower colorectal cancer screening rates, rural communities, certain racial and ethnic communities, low-income communities, among others. So in short, the 80% in Every Community campaign is our commitment to continue working to bring down barriers to screening because everyone deserves to live a life free from colorectal cancer. Our mission won't be achieved until we see 80% screening rates in every community. I also thought it was important to quickly level set on some national indicators for colorectal cancer screening progress. For more in-depth information on this topic, I direct your attention to the NCCRT website, where we have an excellent webinar recorded where we reviewed 4 key national data sets. I'll quickly cover some of those data points here. First, our friend and colleague, Dr. Janaba Joseph, shared some information from the BRFSS. She shared that of the 86.6 million adults aged 50 to 75 in the U.S., 22.2 million of those have never been screened for colorectal cancer. Here we see progress is being made. Here on this next slide, we see progress is being made, going from 65.2% screening rate in 2012 to a 67.3% screening rate in 2016. And while that doesn't seem like it's too outstanding of an increase, we know that this rise has accounted for 5.1 million more people up to date with screening from 2012 to 2016. And we know from Dr. Joseph's other great work that we are seeing some of this excellent progress across the country. Certainly because of the energy and time many of you on the phone have put into prioritizing colorectal cancer screening and joining the 80% campaigns. This slide tells us that when we look at those unscreened individuals, a majority of those folks, 18.2 million, are 50 to 64, generally that pre-Medicare age population. And the HEDIS data here kind of paints a little bit clearer of a picture of what those differences look like between the commercially insured and those on Medicare. As we look down the right column on this chart and consider, this is back to BRFSS data, but as we look down the right-hand side of this chart and consider the cyber screen by race and ethnicity, we see that we still have substantial work to do across most demographic areas as well. And so whenever we can kind of conclude on BRFSS thoughts, there's progress being made, but there's still a lot of attention that needs to be paid to those 50 to 64, those insured, those uninsured, Hispanic populations, and really pretty much everyone. So, and then also people aged 65 to 75 looking at American Indian, Alaska Native, Hispanics, those have low income. The National Health Interview data also tells us a similar story. Whenever we look at those populations that are under 50% for this survey, we're looking at 50 to 54-year-olds, Hispanics, people with less than a high school diploma, the Medicaid and uninsured. But we also know that there's characteristics of those that are not up to date to screening that may or may not surprise you. So over a third are 50 to 54, 2/3 are white, over a half at least have some college education, and as well as private insurance, and a quarter have Medicare. In 2018, the American Cancer Society updated their colorectal cancer screening guidelines and now recommends that colorectal cancer screening begin at age 45. The American Cancer Society firmly believes that the evidence, including a concerning trend in colorectal cancer incidence in younger adults, now points to colorectal cancer screening initiation starting at age 45. So alternatively, the United States Preventive Service Task Force still recommends colorectal cancer screening should begin at age 50. And we recognize that while some organizations will implement policies to begin screening at age 45, others will continue to follow the USPSTF guidelines. So the NCCRT supports member organizations in advancing their life-saving missions around colorectal cancer screening, no matter which colorectal cancer screening recommendations they choose to follow. And the messaging guidebook will be useful whether an organization begins. Now for the main show here, the 2019 messaging guidebook. The goals of the market research were to measure general awareness of colorectal cancer screening methods, understand the rationale, attitudes, and motivations for being screened or not, analyze priority populations such as people aged 50 to 54 and the marketplace insured, identify logical and emotional drivers that could encourage screening use, and use the drivers to create and test messages that would motivate unscreened people. This research was conducted over 3 phases of work. Phase 1 was a 15-minute survey to measure general awareness, understand the rationale for screening or not screening, and uncover any potential motivators to encourage screening. Phase 2 incorporated 45-minute in-depth interviews to dive deeper into some priority populations. And Phase 3 was, again, a 15-minute survey, but this time we were testing 13 different messages drafted from the findings from Phase 1 and Phase 2 with those in mind, and we're really meant to motivate the unscreened. As we look at what's in the guidebook, the general profile of the unscreened individuals, their defining characteristics, behaviors, and attitudes, description of potential motivators for screening and likelihood of completing screening. It provides recommended pathways for message delivery, the who, the what, the why, the how. Introduces the top 3 preferred messages in our market research. And it also has one-page deep dives on priority populations. And I have just show an example. These are the particular priority populations that we'll look to cover: the young 50, insured, rural dwellers, select racial and ethnic groups, people aged 45 to 49, and then also some psychographic personas there on the right: fearful delayers, invincibles, preoccupied busy bees, financially challenged. And each of these will kind of get their own, 1 to 2 page spread that I think work really well and kind of give you a flavor of what's needed to start motivating these folks. I also direct your attention to other complementary resources we have within the Resource Center. A messaging guidebook for Hispanics and Latinos, one for Asian Americans, and also some other little one-pagers on working with celebrity ambassadors, earning your earned media. Those are in the Resource Center at the NCCRT website. Finally, on releasing the guidebook. So the guidebook becomes available next week during the week of July 22nd. We're going to be distributing to all those registered for today's webinar, but also through CRC News, social media channels, and on the NCCRT website. What we're really asking folks to do is join us in this opportunity to release this because it is such a popular guide. We really want to get out there and disseminate it better. So we're asking you in your evaluation to sign up if you're interested in helping us find this, to disseminate this. And we'll share a newsletter blurb with you, some social media messages that you can use to help us really promote this toolkit and get it into the hands of the people that need to see it. And so with that, I'm going to pass the mic over to Michelle, who's going to go into all the exciting stuff that you all came to learn about.
Great. Thanks, Caleb. So as Caleb previously mentioned, we conducted 3 phases of research. We did a survey and some qualitative in-depth interviews to really try to understand the unscreened base, their behaviors, their rationale, their barriers. And then we conducted a final phase of research where we tested different messages to see what resonates best among the different audiences of interest. So here we're focused on the 50-plus-year-olds that are unscreened. As we move through, we like to start this off with this quote. So fighting emotion with logic is like bringing a calculator to a knife fight. As we review the research findings, you'll see that there is emotional barriers and elements that are preventing people from getting screened. The choice to remain unscreened is not really a logical one, you'll start to see, but it's more driven by emotion. So first, let's understand what the unscreened base does from a health perspective. So the majority say they care a great deal about their health and they know what they need to do to stay healthy. Their health has become more of a priority for some because they're starting to feel the effects of aging. And so they're doing things like exercising, they're eating healthy. Some even told us, you know, we're getting enough sleep, trying to make sure we get enough sleep. They quit smoking. There are some who did indicate that maintaining their health right now isn't a focus because they're focused on taking care of their family members. So they're serving as a caregiver and they're kind of putting their needs on the back burner. So what they aren't doing. So the majority of the unscreened, they're not getting annual physicals or visiting a healthcare provider for wellness checks. Even those that do get an annual physical, it's usually for some underlying reason. They need a refill of their medication. They have to get a physical for work. It's not a measure they're taking to be proactive about their health. There's usually some reason driving them to that physical or wellness visit. And so half the unscreened base, they admit to being doctor averse. They try to avoid going to see healthcare professionals at any cost. Reasons for this span across concerns with insurance or costs. We'll start to see some of the emotional elements pop here, fear of getting bad news, just general distrust of the medical field, as well as scheduling issues. So while the majority, they're not getting physicals, what's interesting is 2/3 of the unscreened base has seen a doctor or healthcare provider in the past year, but it's often triggered by a specific issue or illness. The other thing to keep in mind is that while 6 in 10 have seen a primary care physician primarily for their health needs, that leaves 4 in 10 that are going somewhere else and they need medical treatment, with urgent cares, NPAs, and nurse practitioners popping up there. And we see a few different demographic differences as well. Just to call out, you're uninsured, they're more likely to go to an urgent care when they have medical needs. Rural dwellers, females, and those with insurance are more likely to see PAs or nurse practitioners. And the uninsured and African Americans are more likely to go to ERs. So focusing now, jumping to colon cancer and colon cancer screening. So when it comes to thinking about colon cancer, top of mind, people describe it as being deadly, fatal, acknowledging it's a terrible illness. Beyond those sentiments, colonoscopies is the 3rd thing that comes to mind when they think of colon cancer. Not necessarily colon cancer screening, but just in general colon cancer. And that ranges from acknowledging that they should get a colonoscopy if they don't really want to, or knowing, essentially acknowledging that they should have one. Many admit they don't know much about the disease. Most are unaware that colon cancer can actually, or that screening can prevent colon cancer. They mostly think it's for early detection. And most don't personally worry about it. They don't have any stomach issues or digestive issues, kind of that out of sight, out of mind, or they have no family history, so they think it's hereditary, and because nobody in their family's had it, they're not really at risk. Many are aware of CRC screening. They've at least seen or heard about it. Advertisements is the #1 channel where they've come across this type of information. And what's interesting here is we did similar research back in 2014, and this is one of the lowest channels for information, and now it's the top. Beyond that, discussions with healthcare providers and discussions with friends and family are also top ways they've heard or learned about CRC screening. And so we're going to look into those discussions a little bit more. So first, discussions with healthcare providers. So about 4 in 10 have had a discussion with their healthcare provider about CRC screening. So what do these discussions entail? It usually is their doctor recommending that they're of age or that they're due for screening. But what healthcare providers aren't saying is what's key here. They're not telling them why it's important or that there's different testing options available. And so part of the research we did early on, we talked to a set of the screened base. And the biggest difference between the discussions they had with their healthcare provider versus the unscreened is that their healthcare provider communicated to them why it's important to be screened. So that's pretty key here. Discussions with family and friends. So half have talked to family and friends about screening. Beyond acknowledging that they're of age, the other most common topic discussed is what the PrEP entails. And when this is discussed, the word horrible was typically used by friends and family when talking about either the PrEP or the procedure. And it's these negative secondhand accounts they're getting from friends and family that are serving as an additional barrier for the unscreened base, and it's starting to feed their fears and apprehensions. And this is particularly true for females. So why aren't they getting screened? We know they acknowledge that CRC is a terrible disease. We know they're aware of screening. You can even see below on the right there that 6 in 10 feel CRC screening is important, so they're acknowledging it's important to do. So why aren't they getting screened? Procrastination, so people saying, I will do it eventually, I just haven't yet, that's a top barrier. And on the next slide, we'll dive into a little bit of what's triggering that procrastination. Then we have those that say lack of symptoms. Again, they're not feeling sick, out of sight, out of mind. They're not getting screened. Fear. So the unpleasantness of the PrEP in particular is driving some to not get screened. And then again, that no family history, no hereditary connection is also a top barrier. For the uninsured, cost is largely what deters them from getting screened. But even among those that do have insurance, they also have some cost concerns. They're not sure what the insurance would cover or what the out-of-pocket costs would incur. And we did have a line of questioning where we asked some people if they've reached out to their insurance company proactively to get this information, and they haven't. So to get that information, they would have to be more so the other way around. So diving into procrastination a bit more. So we looked at this across different demographic groups, but being busy, top driver just not really having time, other things going on in their life. But fear, so that emotional element, plays a role and is particularly more prevalent among the older unscreened, females, African Americans, Hispanics, and Asians. Cost also pops up as a reason for procrastinating among African Americans as well. So by understanding the barriers and the behavior of the unscreened base, it helps us further profile and create these psychographic personas. We have our fearful delayers as one of them. So those are people that have not been screened or are procrastinating because of concerns about the PrEP, the test itself, or just fear of bad results. We have who we're calling the invincibles. These are people that have not been screened, either because it just doesn't seem important, they have no family history, no symptoms, they live a healthy lifestyle, or they just don't think they're likely to get colon cancer. Our preoccupied busy bees, these are people that are just either focused on other health issues, they just don't have time, they can't take off of work, they're busy being a caregiver for someone else, make up another category group. And then we have our financially challenged. So these are individuals that either have a household income of $40K or less, or they're uninsured. On this screen here, it kind of breaks out the baseline likelihood to get screened. So without any type of influence or messaging, just the current state of their likelihood to get screened. And you can see how the various demographic groups fall here. But with regard to those personas that we looked at, the invincibles, so the people that just don't think they're likely to get it, or because they're healthy, don't have symptoms, as well as the financially challenged, below average likelihood to get screened, so harder to move the needle for that group. So what could motivate screening? Well, many face stomach issues, so feeling symptomatic, that could trigger them to get screened sooner than later. A personal connection, so someone they know having colon cancer could trigger them to get screened. Or their doctor really pushing the issue. So here we start to see more of their doctor pushing them to do it, telling them why it's important. What can make it easier for them and motivate them to take action? So a different, better test. If you remember, the third thing that came to mind when they thought of colon cancer was colonoscopies. So if there was a different or better test that they're aware of, that could help. Lower cost, if they have better insurance coverage, could help as well. And then education on why it's important. So again, that need for education. Now, many think prior they'll feel some anxiety or dread, either about the prep or the procedure themselves, or even just about getting bad results. But what's interesting is most people noted that they know they should do it, they know they'll be scared before, but that they'll feel relieved after. So again, the logic of knowing they'll feel relieved after but still not doing it, kind of that tug of war with the emotions and logic. So how can healthcare providers first better influence screening? So first, let's look at the who. So currently needs to be all medical professionals, not just primary care physicians. As we saw, 4 in 10 primarily see someone other than a PCP. So any health professional, regardless if that's a nurse practitioner, a PA, a nurse, should inquire about whether patients have been screened, and if not, inform them that they should consider it. So when? Again, we know the bulk of the unscreened, they're not regularly getting physicals or going for wellness visits. So regardless of the appointment type and ailment, healthcare providers should really consider bringing colon cancer screening up every time they encounter a patient over 50. So it might be a little strange, they're there because they pulled out their back and then you bring up colon cancer, but that might be your only opportunity to have that discussion with them. And what to discuss, so that why is critical. They need to push the issue more, going beyond just telling patients why it's needed, and highlight why it's important, educating them on the preventative aspects of it, or the benefits of early detection. And then also, what testing options are available. So a lot of times we heard people say their doctor comes at them and says it's time for a colonoscopy. They hear that, they shut down, they don't want to think about it anymore. So really, even if that's the healthcare provider's most preferred, it's important to communicate that there are other options, what they entail, even the pros and cons of what the different methods include. Okay, so it's important to, what we're saying, appeal to the head, so kind of educating, and to do this, discussions with healthcare providers is the leading channel for this. They're the most trusted source for information. They're who the unscreened base want to learn from. And some also do turn to medical websites. But it's also important to appeal to the heart, so kind of fighting emotion with emotion. And TV ads leads as the top channel to effectively communicate motivational messages. There is some benefit to radio ads and direct mail as well. And this slide kind of just reiterates that. Of course, the most trusted sources you'll see here are medical professionals. But beyond medical professionals, national health orgs like the ACS lead as a trusted source for colorectal cancer information, as well as health insurance plans. And I noted this earlier, but you can see just a very small group has actually looked at what their insurance covers. So insurance companies proactively perhaps passing that information along could be beneficial. So finally, based on our research findings, 13 messages were crafted and tested to see what would motivate the different audiences within the unscreened base. And as you can see here, there's that a colonoscopy isn't the only option message. Message that communicates that colonoscopies aren't the only option, that performed the best. There's also this right now message, and we'll show you the messages in more detail, that kind of talks about the preventative nature. And then there's another alternative preventative nature test message that also performed well compared to all the others. So why did these messages work? So 2 of the top 3 messages talk about alternative testing options and the affordability of it. But that at-home piece in the message 1 seems to be a real differentiator. That number 1 message also has something for everyone. So the point about tests being done at home, that addresses fear and increases comfort. The simple aspect of it kind of caters to those busy bees, so those that are worried about the time commitment associated with colonoscopies and tests. And then the affordable aspect, so those where cost is a leading barrier, you're uninsured, you're financially challenged, this, reaches them on a particular level. One thing too, that second message, this right now message, it was often described as one that made people think, and it was scary enough to motivate them. So this message did well because it kind of, brought a level, conveyed a little bit of fear to convey why screening is important. When the unscreened base was exposed to this number 1, this leading message, it had a positive impact across different demographic groups. 1 in 4 unscreened 50-plus-year-olds indicated they would be likely to get screened after seeing this message. And we saw the same positive shift in different persona psychographic groups. So the most preferred message, it had a positive impact across these groups. Even those harder to reach groups, the financially challenged and the invincibles. So, and if you remember, they were on the below average likelihood to get screened before any exposure to messaging. So with the goal of the 80% in every community, we looked at this research and cut it by a wide array of different demographic groups and profiles, which Bill Willard is going to give kind of a high-level walkthrough of those, as well as we did talk to some 45 to 49-year-olds, which Bill is going to cover as well.
Thank you, Michelle. So when we set out to do this research, again, we had some target groups that we were specifically looking to know a little bit more about. So in these next series of slides, it's kind of a composite of everything you've just seen Michelle present, but at a very targeted demographic level. So the first one we're looking at here is a profile of the young 50. So these are people that just have recently come into age of the previous guideline of 50. So they're pretty new to the whole colon cancer screening discussion. Interesting things about this particular group are that the messages that are impactful for them kind of fall right in line with the general population, which Michelle just presented. That just even the rank order of how they appeal to this particular group falls right in line. About half of them consider themselves healthy. Half of them also say they exercise on a regular basis. But the barriers to screening for this group is definitely procrastination, but it's procrastination essentially driven by their busy lifestyles. Remember that these are young 50s. Most of them are still working, and they have families that they're dealing with. So, and also other barriers that popped for this particular group was that they were asymptomatic. They didn't have any symptoms. And also because probably they were on the cusp of that 50-year-old age definition, the doctor had not yet discussed it with them. Some differentiating things about this particular profile is that they over-indexed on being employed, which is not a surprise. because they're of working age. They also over-indexed on being married, having children, again, dealing with those things. And also, due to the fact that they're working, they over-indexed on income. So some of the things to note about this group is that because they're so busy, maybe communicating to them the simpler options, the ease and simplicity of home tests could be an important thing. And also, one thing to factor in is this, the feeling of being asymptomatic. That secondary message of the right now kind of would be something that would be helpful for them to know too. Kind of just gives them food for thought about, I may not be feeling anything, but something could be happening. This could be a trigger for me to go be screened. Another group we looked closely at is, if I can figure out that, there we go, is rural dwellers and how people in rural communities responded to the questions that they were posed. So again, messages were very similar. The top 3 messages pretty much hit. This one, with the rural dwellers, it was more about, it wasn't so much the right now message about the polyps. That kind of dropped to the 3rd position for them. For them, it was more about the other options and the affordability. So, because you can see the procrastination issues for this particular group were, again, they were very busy. When you think of rural dwellers, we have a nice picture of a farmer here, but yeah, they're pretty busy, no doubt about that. Also, top reasons for them not being screened is that they're asymptomatic and they have no family history. But here's where costs kind of popped as a top barrier here for this particular group. Demographically, they kind of mirror the general population, but they did over-index on being white. That's not necessarily a huge surprise. So the procrastination for them were driven by them being busy or worried about the prep. That was another thing for this group. So for them to know that there are alternatives and easier tests, that could be pretty impactful for this group. Over half of the group are kind of a doctor reverse, so they don't go to doctors for regular checkups. So reaching this group might be we have to be a little more creative with this group, going beyond, discussions with healthcare providers. The next group that we are looking at, I went a little too fast, are the ones we call the fearful delayers. So the fearful delayers are the ones that haven't been screened because they fear the test itself. It's not so much that they don't have the means to be tested, they're just scared of the test. So again, the fact that the #1 message here again was for the option of, there are simpler, more affordable tests, that resonated with this group. But also the fearful delayers, and one thing that's pretty interesting here is the theory of fighting fear with fear. So they're fearful of being tested. They've heard about the prep for colonoscopy. They don't want nothing to do with it. But that right now message resonated with them or could be a trigger for them. So it's meaning of fight fear with fear. So that right now message really zeroes in on, the unknown. What could be happening inside of me that I don't know? So, that's an interesting angle with this particular group. Because prep concerns, again, really popped for the fearful delayers, and then being asymptomatic as well. This group, they were more apt to, be dealing with family and children. But interestingly enough, their insurance status, they over-index the general population. So it's not insurance, it's not necessarily the affordability for this group, it's the fear. But interestingly enough, a lot of them have had a connection to cancer. So, those are some really kind of interesting tidbits that distinguish this fearful delayers group. The next group is the preoccupied busy bees. So these are the people that just don't have the time. They're working, they're out there. It's not important. They haven't placed this in the importance of their huge schedules that they have in front of them. From a messaging standpoint, again, the two things that popped the most were the ones that discussed alternative options, so simpler options. Again, this group are sometimes busy bees are, they're procrastinating because they're busy, but they're also procrastinating because this particular group anyway, because they were focused on other medical issues that they had. And then, again, being non-symptomatic, asymptomatic. But demographically, again, these people are employed. This particular group over-indexed ethnically as being more white than the general population. And again, insurance was not necessarily the cause for them not to be tested. So among this group, being busy or worried about the PrEP, so among this particular preoccupied busy bees, this is a group, they're currently focusing on other things. So how do you best get to them when CRC screening isn't really a high priority? I think the best way for that is through trying to get to them through messaging about the at-home test, because that's pretty simple for them to do. And then again, trying to address the fact that testing is preventative. It's a preventative part of the screen. It's not just prescriptive. So the next, is that the last group? Yeah, so in essence, for next steps, what we really need to do here is to, and this is overall to the overarching what Michelle talked about and also the profile groups. Moving forward, what we need to do as a group is to figure out how to change the way healthcare professionals approach CRC screening with patients. Make sure that it's top of mind, make sure that enough information is given about testing options and the importance of the screening. And then also developing targeted messaging that's going to inspire action. So in closing of this particular piece of work, this is a great quote, is that when dealing with people, remember you're not dealing with creatures of logic, but creatures of emotion. So throughout this, I think you may have noticed the recurring theme of the heart versus the head. And in terms of trying to get people off the fence and be screened, it's going to be the heart that's going to ultimately win out of that battle. So one of the nice things that we were able to do as part of this research, and this research was conducted right around the time that the American Cancer Society had shifted its recommendation of screening to be 5 years earlier, we were able to do a subset of work focused just on the people who were closest to, who most impacted by that guideline. So we're talking about respondents who were between 45 and 50. So we actually surveyed them as well. So again, another quote about this is like, when you can change the mindset, everything on the outside will change along with it. So at this juncture, because this was so fresh and new, it's all about just, trying to figure out how best to communicate that it's probably a better idea to be screened at a younger age. So what do we know about the 45 to 49-year-olds? Of that group, 1 in 10 had already been screened, which is, that's just 10% of the group. The most often cited reasons were definitely because there was a family history there, for sure. And again, the people within this age range who had previously been screened had been dealing with a medical issue. Their doctor recommended it probably because of their family history. But of that 10%, 74% had a colonoscopy, And 61% were actually less than 45 when they had their screening. So again, that family history was recognized among this group, and they were being proactive in being screened. So in terms of barriers, 76% of this group actually felt it was really highly important to be screened. It's just that in their minds, they were figuring, or their doctors had drummed into their head that age to start being screened was 50. So when they're talking about barriers, it's like, well, my doctor didn't recommend it. Again, being asymptomatic was a big deal. Procrastination was important, but you can only procrastinate when you can't necessarily think of it as procrastination when you didn't think you were supposed to do it, because finally a lot of these people in this group felt that they were too young to be screened. So again, introducing them to the thought that 45 is the new ACS guideline anyway will be helpful to get that message out there to get them to be screened. So one of the nice things about this group is over 2/3 of this unscreened 45 to 49-year-olds have been treated by a healthcare professional. That's a pretty strong count. So they're not necessarily, only 1 in 3 are doctor reverse. I think earlier when Michelle was presenting, I think it was almost 5 in 10 of the general population would consider themselves doctor reverse. But when they do go to the doctors, 64% go to their primary care physicians, and some others go to urgent care or physician's assistants or practitioners. But the good thing here, too, is that, close to 90% of this group have insurance. Now, again, the issue with this particular group, as we know, is the insurance companies catching up to the proposed new guidelines. So we can't accurately state that this particular age group wouldn't have some issues with insurance at this juncture until new guidelines are fully adopted across the industry. So what do we do? What are the first steps for motivating 45 to 49-year-olds to get screened? Again, it's just getting it on their radar and getting healthcare providers on board with the revised screening ages. So it's really important. We saw throughout the research that, conversations with the doctor were probably the most important and impactful. But now it's the job to get healthcare providers to recognize these shifts and to start recommending screening at this earlier age juncture. And then we just need to educate the younger population. So most people had that program mindset of 50, so whatever we can do to shift that to be younger would be helpful. Again, different testing options, that's always a key to make things easier on the screening side of things. And just educating them on how screening can prevent colon cancer versus just detect. I mean, you can never discount I think within the research we saw a lot of people indicating that they thought that colon cancer screening was definitely not about prevention but about detection. So whatever messaging can be put forth about you can actually prevent yourself from getting this, especially to this 40 to 45 to 50-year-old group, would be really helpful. So I think that pretty much wraps up the bulk of our research. So I'm going to go back to Caleb, who may have been monitoring the chat room. So, Caleb?
Yeah, thanks so much. That was absolutely fantastic, and I want to thank both Michelle and Bill. Like I said, they've been tremendous in this process and working through this data and helping us analyze it, and really have picked up some great information. And I hope you start to see really how much we have to draw from here. So There are a few questions in the chat box. Just first off, as a reminder, we will be sending out the slides post the webinar as well as a recording of this particular webinar. So we definitely want and encourage and hope that you all will share this. You've found this valuable and will share this with us as you're able to. So we have about 15 minutes. We have to the top of the hour to address any questions that folks have. And Bill and Michelle, I'll just kind of read through them and I'll pitch a few to you. And the first one that came across was specific to trying to find ways to reach out to urgent care. The patients are using urgent care more and maybe finding ways to better engage them. And I'll answer maybe just broadly and quickly that, you know, I think that in the findings that we had, we were able to survey folks, I think 45 to 49-year-olds, it's about 13% were using urgent care, and for 50 plus, it was about 15% using urgent care. So it's definitely a place that they go. And I think that, at least from the market research findings, from my understanding, would be that if completely a right thing to do to engage them and finding out ways to share this information with them and share, you know, just generally about how a healthcare provider can help motivate folks to screening. So I don't know, Michelle or Bill, if you want to add and elaborate on that at all.
No, I think you covered it well. It's, I think, strange for some people to, you know, for many people to wrap their head around when you're in urgent care. It's kind of putting out a fire, right? You're there for what they need to be treated for, and then you're on to the next. Same thing with ERs. But it can be a quick conversation, get the conversation going, even if it feels like a strange fit. That is the only opportunity to reach a subset of the unscreened base.
So this is a good one from Greg, and I think something we've noted before, that within our data, and maybe Michelle, you can speak to this about how exactly, or the reason why we chose to kind of classify nurse practitioners or physician assistants separately from primary care, and why we were separating those out, knowing that often these are considered as, you know, part of the primary care physician. They do serve as primary care physicians.
I believe when the survey was crafted, we had not only experts from the ACS, we had physicians that actually helped craft that survey, and they wanted to understand the distinction between people that are going primarily to a primary care or who are seeing nurse practitioners, and any differences that lay in there. So it was a design element, and I believe the separation of that on the list came from those in the medical profession who were helping inform our survey.
Sorry, I'm reading through some of the questions. We have a lot coming in at this point. So. So to Eric, the question here, will materials be coming out for patient and provider use, including the new age 45 guideline from 80% of the community? So the way that the National Colorectal Cancer Roundtable is approaching this, the differences in the guidelines, is that we're trying to develop resources that still educate about the differences between the guidelines and that are available and useful and inclusive of all those guidelines. So as much as we can, definitely always trying to introduce that there is a discrepancy within the guidelines currently, both USPSTF and the American Cancer Society, explain what those differences are where appropriate, but still, you know, utilizing materials in the messaging guidebook or developing materials that would be helpful to, I think, to whether you initiate screening at 45 or initiate screening at 50. Yeah, I'm reading through some of the questions too. I'm looking to see if there's any specific to the guidebook as well for Michelle and Bill, so that's why a little bit of hesitancy here. So, Bill or Michelle, I guess one thing we can think about is maybe from your perspective, from what you learned and analyzed, is as USPS, maybe getting your impressions on the differences in the screening guidelines and how maybe participants that are on the call can approach providers adopting the 45-year-old screening start, or maybe, so thinking about, we know that one of the steps we need to take is some of the messaging to providers about the information that we found, not just with us, just maybe public health professionals, but providers need to be a part of this conversation as well. So maybe navigating some of the differences of this. Any thoughts?
Well, I mean, I think, again, this is early days. So, again, I think the guidelines were updated, the ACS guidelines were updated maybe less than a year ago now. So it's tough because just figuring out how to get the doctors on board beyond just them acknowledging that the guideline, there has been a shift in guidelines. It's definitely a challenge, maybe through some of the facts and figures that will be coming out within the guidebook could help getting primary care physicians on board. Michelle, did you have any thoughts?
No, I think you catch up pretty well. It's early days. The biggest issue is not issue because it wouldn't be expected to be high, but it's very low awareness of the current guidelines at the moment. So we need to increase awareness first. But even once made aware, a very large subset of people said they're going to defer to what their doctor or healthcare provider recommends. So it's really the next step is getting medical professionals on board, because even if 45, 49-year-olds are aware, there's a large subset that are not going to get screened if their doctor's not recommending that age.
And then this is an interesting question, but I think maybe we can speak to it from our market research. So the question is, while we're able to locate individuals who are willing to be screened, the issue is that providers are maybe not ordering FIT, Cologuard, or colonoscopy unless they've seen a patient within the year. And I think that kind of gets to a few things. One, making sure that providers are asking or showcasing the number of options, but then also getting at the fact that a lot of the folks within that we were surveyed, a good portion of them, around 50% or more on average, are doctor adverse for the unscreened, and only seeing physicians not for annual physicals or any sort, but only seeing if they need a medication refill or maybe if there's some injury or something that they have to go see the doctor for. So I think it's finding different opportunities within the community to put a healthcare professional in front of these folks, and also knowing those different healthcare professionals, know the options and know the efficiency of the different options. Anything more that you, Michelle or Bill or Emily, I know Emily, you're on the call as well, that you want to comment on that particular question?
No, nothing else to add.
A couple of other things, just to touch on a few of these other questions. So one question about if the United States Preventive Service Task Force, about changing their recommendations, as most organizations are following those. Again, I think our guidebook will be able to address that and definitely understand that. It's why the focus mostly is on 50+. Plus, that's where we know the data that we have currently. At the same time, I do know that USPSTF is currently going through a review process of their guidelines. It'll take a year and a half, 2 years to go through this process. But it'll be interesting to see, as they have some of the information the American Cancer Society has and reviewing their guidelines, to kind of see how it all falls out and plays out. So this will be kind of an ongoing issue throughout the 80% Every Community campaign that we'll be monitoring, but again, from the roundtable's perspective, we'll be looking to include and make sure that our resources are helpful for all. A few other things, a few of these other questions, I would just recommend and encourage folks to look at the Resource Center. While we'll be releasing this messaging guidebook next week, and it covers a lot of consumer-facing type messaging that we can do, and updates some of the information that was in the last communications guidebook. There are other resources that we have that are more specific to hospitals and health systems, and about how health professionals can work within those systems and improve the best practices there, with case studies included. Also information on working at community health centers and including community health workers within the process. So I think that this resource, as well as the suite of other NCCRT resources, can help complement the work that we are all doing. With that, I think we're about to the top of the hour, so I will maybe wrap us up here. But I do just want to say, and again, thank both Michelle and Bill for speaking and generously sharing their time and expertise today. It's a lot of information to get through than we asked them to go through, and I think that they really condensed that down very well. We also want to thank CDC for helping provide funding for this particular webinar, and the American Cancer Society provide funding for to be able to do the research and put out this particular resource. Whenever you guys get your evaluations, it would be awesome if you wanted to join us in disseminating the information next week. We'll be giving you some blurbs to use within internal or external newsletters that you send out, as well as some social media stuff, so that we can maybe get this spread a little bit further, even more than last time, as this was one of our most popular resources last time. We encourage you to find the NCCRT on social media, and if you have any hanging questions, please email those at nccrt@cancer.org. And if there's any questions we didn't get to in the call today, or that we see any after the webinar, we'll send those out along with slides and the event recording. I appreciate everybody's time, and I hope you have a good afternoon.